everyone, and welcome to this Q&A session. My name is Jennifer Persaud, and today I'm joined by JP Caneiro. Hello and welcome, JP.
Hi, Jennifer.
Hello. Now, I just thought we might start off with you giving us a very brief overview of what osteoarthritis of the knee actually is.
Sure. So osteoarthritis is basically an inflammation of the joint. So it's a joint response in which you have an inflammatory process. They alter the structure of the joint. So when you look at the structure of the knee, for example, the cartilage of the knee will change in response to these inflammatory changes. And the changes are not only on the cartilage, but also on the soft tissue that involves the cartilage, the joint itself. And these changes, they can alter in severity. So some people may have lower level changes and other people may have higher grade changes. And these are visible on a plain X-ray. And these structures, they can become sensitized. And probably the word "can" is really important here because it's not everyone that will develop pain as a consequence of having altered changes in their bone structure. In terms of what characterizes osteoarthritis is that you can have these changes, but you can also develop pain and functional limitation as a consequence of that.
So is a scan or an X-ray by itself useful in making a diagnosis of OA knee?
No, the short answer is no. The X-ray, which would be the most commonly used diagnostic tool or imaging for people with knee OA, it just tells us about how the joint looks. But the diagnosis of OA is a clinical one. So that means that a clinical assessment is imperative. And if we look at the international guidelines, in fact, they say that if the person presents pain and functional limitation and they are over the age of 40, plus or minus stiffness in the morning, they can be diagnosed as having a knee OA. So you don't need a scan. In fact, when you look at the use of scans for diagnosing knee OA, it can actually lead to an escalation of care, and it can lead to overuse of the health services because of that scan.
You recently published an editorial piece in the British Journal of Sports Medicine just last month. Yes. You did mention in the article that it's really important to consider OA knee as a whole person condition rather than a single joint condition. Could you expand on what you meant by that, please?
Yeah, absolutely. So what we mean by that is to say that knee OA, and especially a person's pain experience, is much more than just a joint. And that's because what we know these days is that a person's pain experience can be influenced by their individual context, by their lifestyle, by their stage in their life. So by several factors that are beyond the joint. So basically, if we are looking at a person's health in terms of their social circumstances, in terms of their biology, in terms of their structure, their physical conditioning, and their lifestyle choices, all those factors can come to play to influence a person's pain experience. So in the past, we tended to look at knee osteoarthritis as being a problem solely of the joint, and it's still a common belief that patients and many clinicians will see that pain that comes from or people presenting with pain, people with knee OA that present with pain, that is directly related to the level of damage in their joints. And what contemporary evidence tells us is that there is much more that can lead to someone experiencing pain than just the structure.
Okay, so there's been some conversation recently around the difference between pain as a perception and pain as a sensation, and the thought process that, well, inflammation, for instance, is a biological process, and that cannot be altered by cognitive processes. Can you expand on that?
Sure. So I think for, if we think of this to the consumers, the biopsychosocial view on pain, it's basically telling us that we are looking at more than just the biology. So if we break down the word and we look at the biological aspect of this view, we are talking about inflammatory processes, as you rightly said, the structure of the joint, your muscle conditioning and size and strength. If you have any, your levels of physical activity, your body weight, and the presence of other inflammatory markers in your system. So all those factors and others will basically comprise this biological aspect. But we also have a psychological aspect, which is, how confident you are in using your body, how worried you are about your body, what is your stress levels. And one of the side effects of stress, or one of the physiological consequences of having, especially chronic stress, is it's an inflammatory one. So there is a physiological change in the body when someone is going through stressful periods, or someone that carries stress in their life. And you can imagine that if you have a knee condition that is painful and it stops you from doing the things that you love, potentially that could be socializing, being physically active and working, or even being able to be mobile, things that we take for granted, that would cause you a level of worry, especially if you feel that there's nothing you can do about that condition. So a byproduct of that is a physiological response. And then we have the social aspect, which is, are you participating at work? Are you isolated, or are you living in a place where you can communicate with others and you're going out and doing the things that you love? And in that regard, these things also affect the physiology of our body. These days we know that something like social isolation can lead to significant changes in the chemistry of your body. And in addition to that, we have lifestyle factors and choices such as, your sleep quality, your diet, your levels of physical activity, of, underdoing or overdoing. So when we look at this biopsychosocial view, we look at this intertwined relationship of all these factors and how they can play or interplay to alter the chemistry of the body and alter the physiology of the body and alter someone's pain experience. So things such as, sleep, stress, physical activity levels, and your body weight, they can definitely influence inflammatory processes. So we are seeing this whole person response.
Okay, thank you. So what you're saying is you're not discounting any one particular system, but that all of those systems all work together to complement one another, and so that we have to think of the person in a holistic manner. I'm just interested in your paper that was published last month. You called for action from clinicians, and there were three main themes around the actions you were calling for them to respond to. Can you just give a summary of what those 3 points were? Yeah,
sure. So probably the first thing is changing the message, and the message is the message that we deliver to patients. And the change in the message is that pain in knee osteoarthritis is not solely related to the structure of the knee. And just making a really clear here at this point is that we're not discounting what happens in the knee joint. You're actually considering that, but you're considering that not as the center of the person's pain experience, but one of several factors that may influence someone's pain experience. So the message that we're trying to promote, the clinicians to promote, is to say, hey, you've got some changes in your knee, but you also have all these other factors that can influence how sensitive that knee can get. And so it's moving more towards an approach where it looks at all potential factors to that individual. So it's not everyone that has stress in their life. It's not everyone that has sleep problems. It's not everyone that is socially isolated, but there are some people that have those very factors. So that's kind of the step number one, which is attending to factors that can be related to a person's overall health, basically. The second step, which is a consequence of that, is a change in treatment focus. The treatment that we see in these days that are following guidelines and following contemporary evidence is to look at all those factors to that particular individual and target factors that are modifiable. And a really important thing for patients with knee OA is that, as we mentioned before, several of these patients will have many comorbidities. So they may have cardiovascular disease, they may have respiratory disease, they may have diabetes. And keeping themselves active with a healthy weight is so important. So we going and seeing the physio, for instance, it's more than just getting exercise for the knee. It's about developing an active, healthy lifestyle that enables them to be healthier and feeling better about their knee. And the third step is, again, a consequence of this, is empowering the patient to have a sensible understanding of their condition. So my job as a physio is to help the person make sense of why their knee is sore and what are the things they can do to alleviate that, but also how can we bridge the gap between where they are and where they want to be. So the third step is coaching patients to put them in charge of this condition, which, if we go back to your early question around, patients that have been, they're isolated because of COVID-19, having an active self-management plan it's imperative in times like this.
Is everyone appropriate for conservative management, or are there some patients that really would be appropriate for review with an orthopedic surgeon?
Yeah, so that's a great question and a really important one to be addressed. So what the guidelines tells us is that every patient that has knee OA should trial non-surgical care before considering surgery. And the level of activity and the level of education, the level of weight loss that they need to do will be individualized. And what we know is that joint replacements, knee replacements, they can be really effective, right? They can be life-changing for many people. But we also know that about 1 in 5 patients may not have a significant change or be the same after surgery. And that is really tricky. The other thing that is quite a staggering statistic is that when we look at the number of patients that are offered and actually go through with a joint replacement, they have never been offered what is considered guideline recommended care. And maybe a lot of these patients have been offered exercise and weight loss, but they go into a consult and they are told that their knee is bone on bone and they should be careful with that joint and they will need a knee replacement. So who in the clear mind would actually try and exercise on that knee? They will try to preserve the joint and not exercise. So there is this mismatch between how we convey the message and what we tell patients to do. So if I tell someone that they have bone on bone and immediately after I tell them to exercise, it creates a lot of confusion for the patient. So what I'm trying to say is that every patient should be offered, even if they have advanced knee OA, they should be offered an opportunity to understand what that means, to have a review and see if there are factors in their life that can facilitate that process, and try to regain some movement and learn some new habits for their knee. Does that mean that everyone will then not go on and have surgery? No, that's not what I'm saying. But one of the things that we know is that surgery can be really useful for patients that have trialed and exhausted good non-surgical care, right? And what that means is that it's not only active, but it has the right dose. And the right dose is regular, graduated activation of your body, plus or minus weight loss, having a really good understanding of what the condition is. If you exhausted that and you've done that for enough time and you haven't achieved your goals, then surgery may be appropriate for you.
I'm just thinking about the current situation that we have with the COVID-19 pandemic, and that as a consequence of that, all the low category elective surgeries have been postponed until we further understand how this will play out. For those people that perhaps had knee surgery booked and that's now been cancelled, or for those people that were even contemplating surgery, even for those that want to continue managing conservatively, what kind of advice could you give them to help them in this interim period while we travel through the COVID-19 problem?
That's a great question, Jennifer. I can only imagine, if I put myself in the shoes of a patient that felt that surgery was going to be the, potential life-changing opportunity for them, and now that's been put on hold, that could create a lot of distress. And as we described before, stress can alter your physiology, and it's not good for you in terms of your general health. So if we look at these circumstances, if you have a plan, that plan should be to stay active, even in the isolation of your home, or if you go outside, you may be walking, you may be riding your bike, whatever opportunity you have. So what you need to do is to seek guidance to get an active management plan. We do have the option, not just us, but physiotherapy is now having the option of telehealth. And that is a great way for patients that don't have a plan or want to review their plan to actually have a consult with a clinician to develop an active management plan and to get some guidance during this tough period. And many people may not be aware of this, but there have been studies, particularly in the knee, that demonstrates that an examination of the knee and the outcomes of knee management via telehealth is just as effective as face-to-face contact. And if we think back at the beginning of our conversation, where we're talking about what are the things that patients with knee OA need, what are the things they need to target, what are the things they need to go for, it's a really active plan, and it's a plan that can be delivered online. So it's not everyone that will need hands-on treatment. So if you're sitting at home and you don't have a plan, my suggestion would be to get some guidance and develop a plan with someone that you can self-manage during this process.
JP, how can people access those services? Is there a requirement to either phone in or go into the GP to get a referral through the chronic conditions management plan to then access telehealth services with the physiotherapist?
We had a really rapid response from private health funds as well as Medicare and WorkCover and ICWA, where they actually are supporting telehealth appointments. So that's a great step towards supporting the community in a really tough time. And if you want to see a private physiotherapist for a telehealth consult, you need to call your GP and get a referral. And many clinicians in particular, and some patients, are seeing this as a deterrent of the service and seeing as an obstacle. But I think it's a way of creating actually a relationship where the patient sees a GP, the GP sends the patient to the physio will do a consult, will communicate back to the GP or the rheumatologist, and so you create a team around that person. So that person is not isolated, seeing just clinicians in the community with no contact with the GP. Of course, if you go into private practice, you can then pay for the consult yourself. But a lot of people are in a really tough situation at the moment. But there are opportunities where you can communicate with someone.
Thanks, JP. We're drawing to the end of our Q&A time now, and I'm just thinking about some final tips and advice that you could leave our consumers and our health professionals with. Are there any national guidelines that would be really helpful to guide health professionals and consumers around the good quality investigation management of OA knee?
Yeah, so I think there are several national models of care for the management of knee OA. The Victorian model of care which was revised in recent years, has a really strong plan. But across the states, the narrative about how you should manage knee OA has an underpinning active approach towards it. So quite accessible for consumers. Credible websites such as Pain Health, where you can find really detailed information about osteoarthritis. You can find patient stories, and there are a few exercise and strategies that are provided in websites like that. That's a WA-based or founded website, but also myjointpain.org.au is another website that is developed by really credible people and high-level researchers and clinicians in the space of osteoarthritis. And of course, the Arthritis Foundation in WA provides several, readily available resources, and they are there to answer questions, and they have a really good place in the community to provide support to people with knee OA.
So I'd really like to thank you, JP. You are very generous of your time and sharing your expertise. I appreciate it's a very busy time for you at the moment. So thank you for being able to provide our consumers and our health professionals with some very sound and credible advice about how to manage knee osteoarthritis and the pain and dysfunction that's associated with it. We really appreciate you giving your time.
Yeah, it's a pleasure, Jennifer.
Okay, thank you.
Thank you.